All right, good morning, everyone, and thanks for joining us this morning for the NCAS Journal Club. Firstly, I'd like to acknowledge the traditional owners of the lands we're on today and pay my respects to elders past, present, and emerging. Our speaker today is Dr. Riati Scarborough. She's a PhD fellow at NCAS at the Faculty of Veterinary and Agricultural Sciences, University of Melbourne. And her topic is fears, finances, formulations, and fractious felines. Influences on antibiotic prescribing in Australian cat and dog practice. Okay, thanks, Ree.
Thank you, Arjun, and thank you to everyone who's tuned in this morning. I can see we've got a mix of people, at least one other vet, and people from human pharmacy and GP land, so that's a really good audience. I've done this work in the influences on antibiotic prescribing in cat and dog practice because I'm really interested. I mean, I am a vet, but I'm also really interested in One Health, and I'm interested in human behaviour and the motivations that make us do the things that we do. And so I'm going to tell you this morning about a small piece of my PhD, which is a vet interview study that I've done. So I guess some background about why I chose to study this topic. I think that how we medicate dogs and cats really does matter. We know that there are AMR problems in dogs and cats, perhaps not as advanced as in some of the medical, human medical areas, but there are still known cases of MRSA transmission from humans to their pets, and we know that there are cases of MRSP going from dogs to their owners, which begs the question, what else is being transferred that we do not know about? And there are obviously with AMR, animal welfare implications if we end up with infections that cannot be effectively treated. There's obviously One Health implications because we have close contact between humans and animals. The microbes definitely move both ways, as I said, and here are some pictures of the kinds of interactions that happened this is my youngest child, and this was when she was a little baby. You can see there wasn't much keeping the dogs away from the children. So definitely close contact there and lots of opportunities for sharing. We know from some of the work that has been done by my veterinary colleagues at the University of Melbourne that there are opportunities for improving antimicrobial prescribing in small animal practice. We've been lucky to have some access to some consultation data from a large number of veterinary practices and also from some pet insurance data looking at claims. And we know that contrary to the Australian veterinary prescribing guidelines, the two most popular antibiotics in small animal practice are amoxicillin clavulanate, so the dog and cat version of Augmentin, and a third generation cephalosporin called cefepime. And I've put that in red because it is obviously a high importance antibiotic that should be used sparingly, but it is extremely popular. And I'll explain to you why that is a bit later. I think it's really wonderful to work in the NCAS group because we can share information and we can learn from each other's work. And I would say that there are a lot of similarities between what happens in human general practice, particularly in the sort of GP parent-child consultation, and what happens in a small animal consultation. But there are some really important differences that I thought I should point out. For example, that from a financial perspective, there are no rebates. There's no Medicare or PBS to cover the costs of consultations and treatments. And very few owners in Australia actually do have pet insurance for their pets. That's different in some other countries, but uptake has been pretty low in Australia. Vets also do their own investigations. So that has, rather than sending someone off to get a blood test somewhere else or do a urine test somewhere else, those things are actually done in the clinic as sort of add on to the consultation, and that has implications for workflow, and it can actually inhibit the use of investigations. Investigations are also very expensive, or can be very expensive for owners, not only because there are no rebates, but because Often you can't ask an animal to just lie still while you do X or Y to them. You do need to often sedate and potentially give a full general anaesthetic to do investigations on animals. So that's another barrier to doing investigations. Vets also sell the medications that they prescribe on the whole. So that means that they carry inventory of medications in the clinic. And that also has implications for what they want to stock, the range of things that they want to keep stock of. And, you know, costs of drugs do come into what they will keep on the shelf. Vets also, much more than I think happens in human medicine, think about the animal's body weight. Perhaps some of our paediatric colleagues think about this a little bit, but I think in general, adult humans are treated as adult humans and transported into this one sort of big basket, regardless of their body weight, which I've always found a bit strange. Vets always are thinking about the body weight of the animal, which has implications for the expense of the course of antibiotics for that animal. Bigger animal, more drug, more expensive. And at the other end of the spectrum, smaller animal, you end up getting into fractions of tablets if it's a tablet, which can be really tricky for owners and for vets. So sometimes what's available, you know, in a smaller milligram dose in a tablet might actually dictate what gets chosen. Animals are also not always easy to medicate. Those of you who own cats may be familiar with this problem. So the other thing that I went into this already knowing is that vets' knowledge about microbes, about antibiotics, and also the way that the animal presents clinically are really only a very small part of the decision to prescribe antibiotics and the decision about what to prescribe. So I really wanted to know what other factors influence their decision to use antibiotics rather than waiting and watching the animal, or rather than doing something else altogether. What influences their choice of antibiotic, the choice of route, dose and duration, and whether they use culture and susceptibility testing. And I also wanted to know what changes would help Australian small companion animal vets to prescribe antibiotics more judiciously. And the idea of all of this investigation was to design some interventions, hopefully, that can support vets to make more responsible, I guess, prescribing decisions. I'm not going to talk about all of these parts today, but I'm going to focus on the decision to prescribe antibiotics and the choice of antibiotic and how it's going to get in there and how much to give. So some background to this, not a lot of qualitative research has been done in small companion animal vets and how they make decisions about prescribing antibiotics. And so far, none of it's been from Australia, although some work was done by Laura Hardefelt that did reveal some of the drivers of prescribing, but she was more focused on the implementation of AMS programs in veterinary practices. So looking at purely the antibiotic prescribing decisions, there's been some work from Caroline King and Matt Smith in the UK. They've done some interview studies with vets and also with pet owners, which is something that I'd like to replicate as well, because I think that interaction between the two is very important. And then from the Anna Mateus and her group in the UK have also done that, some work. There's been some work from the Netherlands as well about what companion animals do. But I would say that these sorts of, this kind of research is actually often really context specific. And I would say that the UK vet practice is a little bit different to Australian vet practice. There's perhaps some differences in the way that vets are educated over there. There's definitely a difference in the uptake of pet insurance in the UK. There's a lot more, I'm sorry about my dogs, there's a lot more uptake of pet insurance in the UK, which results in lower out-of-pocket costs for investigations and for treatments. So that may change what people prescribe and how they make the decision. They have a national veterinary registration in the UK rather than the fragmented state-based system that we have in Australia. And it seems to me, at least, I don't have any evidence for this, but there seems to be a higher engagement between UK vets and their professional bodies, such as the British Small Animal Veterinary Association. So there are maybe some cultural differences as well, and maybe some socio-economic differences in the UK that influence prescribing. So I thought it was important to investigate it in our context. And you can't get this kind of rich data from a survey. So I had to do some in-depth interviews, and I really wanted to do my interviews in person, but due to COVID, I ended up changing to Zoom. And apart from a couple of initial disasters where I forgot to press the record button and the internet dropped out, it was actually a really good way of interviewing people, and it encouraged me to sample vets more widely than I would have done perhaps if I had to see them in person. So I managed to speak to 22 vets from all around Australia. And I was initially planning to only interview vets from one particular group of clinics, but I then changed my strategy and I recruited vets from all sorts of places. One of the main places that I went was to an Australian veterinarian Facebook group, and that gave me a great group of people to interview, but they tended to be from a particular demographic, and so I needed to purposefully fill my sample with some people from my personal networks, because there weren't very many male vets who contacted me through the Facebook group, and they tended to be younger vets there. So I did actually go out and find some other people to fill some other demographics. So I had, as I said, a mix of people, different ages, different seniority within the practice. There was a predominance of female vets and vets in their 30s, but I think that's probably a reflection of the profession as well. I had some vets who only worked in small animal practice, and then some vets who were in mixed practice settings but did treat a lot of small animals. They were from metropolitan areas, regional and rural areas across a number of states, and I surveyed them beforehand to find out their level of interest in antimicrobial stewardship, and so I had a mix of different levels of interest. I had intended to only speak to vets for 60 minutes, but I ended up talking for a very long time, mainly because I thought it was just fascinating, and it was enjoyable for me. You can see I'm talking to a friend of mine from my year of vet science, who used to be a housemate of mine in our first year in our grad year. So it was just fun talking to people and finding out what makes them tick. And my interviews were really designed to explore a lot of different areas. So I was looking at what they know about antibiotic use, but also mainly about their decision processes, the challenges that they face, and as I said, some of the solutions that they thought might be helpful. So to get people started, I talked about a couple of case studies. I talked about a female German Shepherd dog who's presenting with her first episode of signs of a lower urinary tract infection. And also I talked about a cat with a history and signs of a cat fight abscess. So the fairly typical general practice consultations in small animal practice. And I asked the vets how they would like to investigate, manage the case. And when they gave me an answer, I would probe them, why would you choose that versus something else? What if I told you that, this owner had difficulty moving around the house, or this owner has 5 children and is extremely busy? Would that change how you manage things? And I might ask also how they might actually suggest a course of action to the client, because the communication piece seemed important. Some other things that I asked were, what are the things that you think about when you're deciding to give antibiotics versus not, and deciding which antibiotic to use? What kind of information sources do you have in the clinic? What do you actually look at? What do you trust? What have been your past experience with antimicrobial resistance in your patients? How do you feel about antimicrobial resistance as a problem? How much responsibility do you feel? Is it something that you are worried about? How could Australian vets be better supported in their decision making? I wasn't planning to do any quantitative work here, but it was interesting to note that of the 22 people I interviewed, only one vet actually suggested guideline compliant management of the dog with the urinary tract infection. In general, vets wanted to treat with a higher class of antibiotic than is recommended in the guidelines. But most notably, they wanted to treat for a much longer duration than the 3 to 5 days that is recommended. So only one person actually had sort of the right choice of antibiotic and duration for that case, and not much better with the cat fight abscess. Generally speaking, once drainage has been established in that case, there was no cellulitis involved in the case. They really didn't need to give antibiotics once they'd flushed and cleaned the abscess, but 20 people decided to give antibiotics, and in most cases they decided to give an injectable 3rd generation cephalosporin. So the biggest theme that I wanted to talk about today is the theme of fear. So fear of omitting antibiotics that were perhaps needed, of choosing the incorrect spectrum, and fear of under-treating the animal because of worries about compliance. Often, will the owner actually be able to give this antibiotic? The biggest thing that the vets fear is clinical deterioration of the case. Obviously, that fear is heightened when the animal already presents with severe signs, where there's unclear diagnosis, and that is often the case because of the issues that I talked about with the cost and delays and the difficulties of doing investigations. For some reason, people were more fearful when the animal was very young. It felt like the stakes were higher. Vets also who felt that their knowledge wasn't very strong, or they didn't have a lot of clinical experience, were more afraid of clinical deterioration. And importantly, vets also are worried about poor owner capacity to monitor the health of their animal and to manage any relevant changes. So really, we're trying to evaluate whether the owner will detect a meaningful deterioration and bring the animal back in, or not. If you don't have faith that the owner will do that, then you're more likely to prescribe antibiotics just in case. And obviously the corollary of clinical deterioration is that the animal will suffer and perhaps might even die. And then that might lead to some feelings of guilt or regret and some other consequences as well. The other big fear is the failure to meet owner expectations. And this was heightened when there was what vets thought was a difficult or an unrealistic owner, and the owner's health literacy really played into whether their expectations were realistic or not. Also in clinics that had developed this culture of we are a place that does, that will fix your animal quickly or we'll do it cheaply, that tended to create expectations of not taking any risk that something might deteriorate by not giving antibiotics. So you always give antibiotics. Where vets that had weaker communication skills also had more fear of failing to meet owner expectations. I think that's, being the communication to manage the expectations was really important. And also the vet's self-confidence played into that as well. The consequences of failing to meet expectations is the potential for owner dissatisfaction. And then the worries about that are that the owner might take action. They might take their business elsewhere. They might complain to or be abusive to that vet or other clinic staff. Sometimes the reception staff get yelled at. Your boss might get a complaint. And in this day and age, also social media slaughter of the clinic, which can be extremely damaging, was another big fear and had happened to one of the vets that I'd spoken to. There was also this overriding fear of, well, what if I get called up to the vet board for not giving antibiotics? And this was due to people's own negative experiences with customers, clients complaining, but also even just hearing about the negative experiences of colleagues and friends in the veterinary industry, that really made people fear the consequences of owner dissatisfaction. And of course, what can happen if the owner takes action is that you can lose, the vet clinic can lose business. There may be a professional or even a sort of social reprimand, and vets are very concerned about the mental health impact of that. And, you know, on a background of perhaps it's not ideal mental health in the veterinary profession. This was heightened when there was a really competitive business environment, when there were lots of vet clinics in a small area. There was a lot more concern about losing a client. Where the clinic culture was unsupportive as well, people were more afraid of consequences. You know, that makes sense. Do my colleagues have my back? If they don't have my back, then I'm more scared of these consequences. And also lack of awareness of the veterinary prescribing guidelines tended to make people more afraid of the consequences. If people knew that the guidelines existed and what they were doing was, you know, printed in a document somewhere as being the right thing to do, they felt that that was a protective thing that would protect them against perhaps being criticised in front of the veterinary board. So fears can lead to unnecessary use of antibiotics, but also using excessive spectrum or duration of antibiotic. And I'd like to share some quotes on fears. I think those are probably the main things that you think of when someone leaves and you haven't given them the antibiotics. You're like, is it going to get worse? Is the client going to ring up tomorrow and abuse me for not giving them the antibiotics? Fear is a huge factor in our profession. The fear of being wrong, the fear of repercussions, the fear of being responsible, the fear of being judged by counsel, which he means vet board, or colleagues. It's a big reason we do what we do. Sorry about that. I'm not going to put myself in a position where I'm going to get yelled at by a client and impact my mental health for the sake of the greater good of antibiotic resistance, because I just don't have the energy for that. You're damned if you do, damned if you don't. I might as well cover my... And this is one of my favourite quotes. You just know the client is going to be difficult and you kind of feel that I've got to do something. If there was a pill, maybe ethoxyline, it's just a capsule full of air and you could just give it to not be in trouble. I think, oh, just go away, you're irritating me. Yes, I'm guilty of that. So there's a real sense of weariness with this daily fear of clients complaining. And understandably, this fear was much more present for the vets than this distant threat of antimicrobial resistance. So another big factor in the decision about antibiotics is finances. And by that, I mean, you know, what finances does the owner have to spend, but also what is their attitude to spending money on animal care? There are people who have the money to spend, but they don't want to spend it on animal care. And so this is, because of the high cost and the delays and the poor availability sometimes of doing investigations to reach a proper diagnosis, that can lead to inappropriate use of antibiotics. And the reasons why there's high costs and delays and all those things, you know, sometimes to do with the laboratory that runs the test, the markup that the clinic decides to put on things like culture and susceptibility, the lack of uptake of pet insurance in Australia, so meaning that everything's out of pocket for the owner. When a clinic is in a low socioeconomic area, that really impacts on the propensity to do investigations. And there's a strong desire from vets to keep the costs low for the owner. So the result of this is that, you know, this high cost and delays is that vet may not even offer investigations such as culture and susceptibility testing to an owner, or they might say it but not really push the owner towards it, or they might offer it and the owner declines it. So vets are much less likely to offer investigations to a client to get to a definitive diagnosis if they have their own financial struggles, sometimes they project those onto the owner. They may have past experience with many owners declining because of cost, and they just sort of assume that the next client will also decline, so they don't even bother. And then another unexpected one was this not wanting to be perceived as a salesman. Sometimes vets do get accused of kind of pushing things that, you know, are unnecessary. So there was that desire not to be seen to be doing that. And all of these things can lead to using antibiotics without a clear indication because you have never actually established a diagnosis. There was also the high cost of extended hospitalisation without diagnosis. For example, in a case of a pyrexia of unknown origin, the cost of having that animal in hospital day after day without a diagnosis pushes people towards doing things like a treatment trial of antibiotics because we don't know what else to do. Sometimes because a preferred antibiotic choice is too expensive, that makes people choose a less preferred choice. So that the expense of antibiotics can be because of what the suppliers, the distributors charge, how much the clinic marks up their drugs, the lack of pet insurance, low socioeconomic area, and desire to keep the costs really low for the owner. Also, having a large animal, you need more milligrams of drug, so that changes the cost of the overall course and might push people to using a less preferred choice of antibiotic. And when there was a long duration of treatment needed, a vet might choose a cheaper antibiotic. Sometimes that led to a more ideal choice of antibiotic because some of the guideline recommended antibiotics are some of the cheaper antibiotics. However, it can also lead to suboptimal antibiotic selection, and it is definitely a sort of non-clinical reason to choose an antibiotic. And I thought I'd highlight these two things. This desire to keep costs low for the owner came through very strongly. And it might be, you know, people might assume that vets want to, you know, make the most money as possible out of each owner, but actually the opposite seemed to be true. They really were very aware of keeping the costs low. And interestingly, low socioeconomic areas were associated with larger animals. So that was a bit of a double whammy in those places where people tended to own bigger dogs, where they perhaps were less able to afford the treatment. So some quotes from vets on finances. This vet felt there was really a choice between either doing investigations to figure out the diagnosis or doing treatment because of cost. So we might have totally skipped all the diagnostic testing because we knew if we did the testing, they're not going to treat the animal. My clients are a little bit more cost constrained, and ironically, I have much larger dogs that I'm seeing in this regional town. Whereas when I was in the city, they're basically like French bulldog, cavoodle, city type. Like I didn't have to worry about having to dose 1,000 milligrams of Kef or something. This vet said, sometimes it's like this is the vet who got accused of being a salesman. Sometimes it's like a little bit of PTSD where in the back of my brain, I'm like, oh my God, are they going to give me feedback that I was a car salesman and tried to sell them stuff? That's not the case. I just wanted to do what's good practice, you know? And another one said, I think finances influence the way I make decisions. Even if I don't have a strict indication for antibiotic use, say a fever of unknown origin, we'll withhold antibiotics for as long as we feel we reasonably can and keep that animal in hospital, but it's hundreds of dollars to do that. So there is a financial incentive to do antibiotic treatment trials. So formulations are a really interesting one, something that vets think about a lot, you know, the weight of the patient, the physical capability of the owner to deliver a particular type of antibiotic, the concentrations available, whether it's a tablet or capsule or paste, Is the tablet coated to stop hypersalivation? How does the tablet smell? Does it taste good? So these are things that perhaps not our medical colleagues perhaps don't think about as much, but these are really, really important when thinking about which antibiotics to give an animal, especially cats who are really fussy, difficult to medicate, and often they hurt their owners when the owners are trying to give them medication. So as a good example, amoxicillin tablets, straight amoxicillin without the clavulanate, which we'd like vets to use, they tend to have a bit of an unpleasant smell and reportedly an unpleasant flavour. But a lot of the amoxicillin clavulanate formulations that vets love to use have been made palatable. So they're a much easier choice from the perspective of getting it into the animal. So the features of the formulations that are available really do affect whether they get prescribed or not. And the things that play into that are, the capacity of the owner to give tablets, pastes, whatever. If they don't have good capacity to do those things, vets are much more likely to use an injectable formulation, and I'll talk a bit about that in a minute. Also, the time pressure on the vet in the consultation setting can affect what they choose, because you do need to teach owners how to give tablets to a cat if they've never done it before. And it's not, it takes time, and sometimes it's fiddly, and if there's if you've got a waiting room with 10 people in it and it's been a long day and you've got only 5 minutes to get this case sorted, you're much less likely to reach for a tablet that requires all this extra work. Difficult animals. I'm thinking about cats, but there are some dogs as well that are not easy to medicate. You might be more, vets are more likely to reach for an injectable formulation where the animal is a little bit difficult to handle. Again, they think about the weight and the dose per kilogram needed. They also might think about the multi-dose bottle of antibiotic that they've got in the fridge at the back, which they need to use up within 8 weeks of opening it. That might make them think, well, I might use that last dose that's in the bottle today, even though it might not be the ideal choice for that particular case. What is stocked in the clinic is obviously really important. As I said, vets will sell the drugs that they have on hand, and the client usually walks out with the tablets or whatever they're getting. And what is stocked in the clinic is decided often by what the bosses of the clinic prefer to use. Sometimes what the suppliers are charging for those drugs. Is the desire to minimise inventory. Vets have said, well, I don't see the point in stocking straight amoxicillin when amoxicillin clavulanate does all the things that amoxicillin does and more. So I'm just not going to stock amoxicillin anymore. They're also, affected by pharmaceutical marketing. Drug reps and lunches can help. There's definitely a big habit factor when it comes to choosing a particular antibiotic, and habit and familiarity with the doses that you need, the contraindications. There might be breeds that can't receive a particular thing. Once you sort of know a drug really well and you're really comfortable with it, then you tend to reach for it more. You know exactly what side effects to talk to the owner about. You've seen it, how well it works in the past, and so there's not a lot of incentive to change if something's been effective. It may be too broad a spectrum, but if it's been effective, you tend to reach for it again when you see a similar kind of case. And this reliance on what you're familiar with is heightened when vets are tired. There's a lot of time pressure. There's no time to think about, well, what else could I use? What might be a better choice? If you're under the pump, you're just going to pick what you know the best. And I noticed that there was a bit of a cycle between what gets stocked in the clinic and what people become familiar with and like to use. And I've called it the dispensary cycle. So what gets stocked is what people use, and what people use is what gets stocked in the clinic. And then this goes on, and it tends to favour having broad spectrum antibiotics and not having narrow spectrum antibiotics on the shelf in the vet clinic. And actually, interestingly, what happens is that vets even may forget that other antibiotics existed. I had quite a few vets say, oh yeah, I actually used to use a lot of amoxicillin. I don't know why we stopped. I kind of forgot it existed. And others said, oh yeah, when I worked in another clinic, I used a lot of TMS, but we just don't have that anymore. And I actually just hadn't remembered that it was an option. So that's really important. Vets are not, sometimes have really just forgotten what exists out there and what they could be using. So the formulations that are available can lead to suboptimal choices of antibiotic, but often also lead to an excessive duration because of a long-acting injection that is available. And there is really only one really long-acting injection available, and that is the cefepime that I spoke about earlier. So what did vets say about formulations? I consider the cost to the client, the formulation of the tablet we have on the shelf, like, is it a tasty tablet, or is it a really bitter tasting tablet? Or is this a capsule that you can't break in half? Or is it tablets that they can quarter? Things like that. I would go with what's easy to dose for the client, depending on the weight of the animal and what's going to be close to that, like only having to give, say, 1 tablet versus 2 or 3, or 1 1/4. I think we're all probably guilty of using a broader spectrum than needed. I probably overuse amoxiclav because it seems safe. Like, you can use it in pregnant dogs, you can use it in young dogs, and I feel like it covers 90% of problems. So a little bit about fractious felines. These are tricky customers, and they're difficult for vets, they're difficult for owners, and they really have played a role in driving up the use of this long-acting 3rd-generation cephalosporin. As I said, it is the most popular antibiotic in cats, I think, in Australia at the moment. Amoxicillin clavulanate might be close behind, but it's extremely popular. It is expensive per milliliter, but because cats don't weigh very much, it doesn't seem to worry people. And as I said, it lasts 14 days. It's really the only available antibiotic in small animal practice that's sort of like a whole course of antibiotics in 1 injection. The other long-acting injectable preparations that we have really only last 48 hours. So there's a long-acting amoxicillin, for example, that lasts 48 hours, but vets often want to treat for longer than that, so you need to then do multiple injections, whereas this is just 1 injection and you're done. So whilst vets were concerned often about the suitability of this particular drug for the things that they are treating, for example, cat bite abscesses, and they were also a little bit concerned about the antimicrobial resistance consequences of using this particular drug, there was a much bigger issue of the convenience of that single injection. There was no need to teach the owner how to get tablets or pastes in. There was no need to worry about, the little old lady getting scratched by her cat. There's no concern about whether the owner would remember to give the doses at the correct time and keep going until they were supposed to finish. So all of those things sort of loomed so large that it made Convenia an incredibly popular choice. And vets said that if they did have a long-acting choice that was a lower importance antibiotics that lasted, say, several days, they would probably use it instead of Convenia, but it just doesn't exist. So it really forces the hand, or it seems to, for many vets, the fact that this one drug is available in this formulation. So the existence of Convenia drives suboptimal antibiotic choice in many cases. It is an excessive duration for most indications. 14 days is pretty long. And I think it also drives the use of antibiotics without clear indication because it's just too easy to give, and you can do it all in that consultation, and then the client's gone, and it all seems really easy. So Vet said, Convenia is so user-friendly. It's really good. Cats are so hard to tablet. You can't sort of hide it in a piece of meat and things like that. Or you can, but it maybe depends on the cat. I think, it's one injection that lasts 7 days. It works for skin infections. It works for urinary tract infections. It's got a lot of uses. Convenia will really be decided by the cat's behaviour more than anything, like whether it's going to stress the cat more than anything to try to medicate it twice a day, or if the client's afraid of handling the cat, or if they're busy and they seem like they're not going to remember, they're too blasé or whatever, then, my feeling would be, at least he has this in his system. So just to wrap up, there were many other factors that influence prescribing. Those were just a few that I picked out. Some interesting ones about the individual case, the day that the animal comes in and the time that they present may actually influence the decision to prescribe antibiotics or not. If the animal presents a Friday night at the end of a long day, and you don't have a lot of time and you're not sure, the vet said they were more likely to give antibiotics in those sorts of cases where they weren't sure that they were going to be able to follow up over the weekend or whatever. They would just rather give antibiotics now than have things go wrong and the owner can't get in touch with the clinic on the Sunday or whatever. The owner capacity to monitor and manage that animal, that was something that vets were constantly trying to evaluate and make a call on. Interestingly, the owner's capacity to cope with uncertainty was something that might influence the choice to delay antibiotics. So if a vet felt that an owner could cope with the fact that there was a risk of deterioration but probably was going to be fine, then they were much more likely to try delayed prescribing and say, please, let's just give it a go without, and see what happens. But some, if they just didn't feel that the owner could cope with that uncertainty, or that they might have a negative reaction to a possible deterioration, then they would give the antibiotics rather than not. The vets themselves, if they had a specialist qualification, they felt that it gave them a bit of gravitas, and the clients were much more likely to go with whatever they suggested, whereas general practice vets felt that clients were much more likely to push back and say, well, no, I'm not going to do that, or I really want you to give the antibiotics, even though the vet's saying, I don't think this needs antibiotics. So there was a difference in the way that clients perhaps interacted with the vet, depending on their status. The way that vets are educated at an undergraduate and postgraduate continuing vet education was also important. If people had been to a seminar where they talked about not using antibiotics for dental procedures, for example, then they were much more likely to do that. Interestingly, vets who viewed antibiotics as an assisting thing for the immune system rather than being the cure in itself, they tended to use shorter durations of antibiotics and be much less likely to reach for high importance antibiotics. So I thought that was an interesting just an interesting thing that came through in the interviews, and may be something that we need to look at conveying to vets. That really is, we are really just trying to tip the balance in favour of the immune system and let the immune system do the rest. We don't have to completely wipe out the bugs with our treatments. Clinic prescribing norms, that's also been found in human medical studies. Professional etiquette was important as well, and I think that's come up in human studies as well. But where an animal has a sort of long-standing or a repeating condition, and the previous vet has always given a shot of Convenia or has always given a 2-week course of amoxiclav, there's an uncomfortable situation where vets do not want to change or go against what has previously been prescribed. So to avoid that awkwardness, they just re-prescribe what's been given before, even if they don't think that it's appropriate. The clinic itself is also an important factor. There are clinic cultural things that I've talked about earlier about, whether it's a sort of supportive culture, but also whether it's hierarchical versus egalitarian. The clinics that had a more egalitarian culture and really valued the input of their younger vets who perhaps had more recent education and antimicrobial resistance, they tended to have fewer issues with doing inappropriate prescribing around routine procedures like desexing. Whether the clinic actually has information resources available to vets, including the prescribing guidelines. Unfortunately, not many vets I spoke to had a copy of the Australian vet prescribing guidelines that Laura Harderfelt has worked on as part of NCAS. So, there's an issue with getting those resources out to clinics. This was a really interesting one that hasn't come up in other studies that I've read. There was a definite role for the vet clinic receptionists and the nurses in creating or not creating expectations of antibiotics for the clients. So from the moment someone calls up to say, this is, my dog has a weepy eye, or, it's got a hot spot on its back. If the receptionist or vet nurse who takes that call says, oh, well, it sounds like Fluffy needs antibiotics, there is the client comes in with an expectation that they will walk out with antibiotics. It becomes that much more difficult for the vet to say, actually, we don't need to give your dog antibiotics today, or at least vets felt that way, that it was more difficult. The way that the clinic charges for a recheck visit may also influence their propensity to, a vet's propensity to use delayed prescribing. Again, that concern about keeping costs down. It might be cheaper for the client if I just give antibiotics today just in case, rather than making them come back in 2 days to see if maybe it's just got better by itself. In order to reduce the cost for the client, I'm just going to give them the antibiotics now. The availability of, some other factors, that the availability of non-antibiotic therapies for some of the common presentations, for example, diarrhea in dogs. When I graduated, pretty much every dog that got diarrhea seemed to get metronidazole, and that may have reduced the symptoms, but I don't think it really did. It was something that was just sort of, it was accepted wisdom and not really very smart prescribing. And what vets have said is that recently, well, I don't know how recently, but in the last few years, something called procolin has come out, and that's a probiotic that comes in a tube that you can give to your dog that does seem to reduce the duration of diarrheal symptoms and make them feel a bit better. So that is something that has really helped. It's something that vets can give, and the owner feels like they've got a treatment, but it's not an antibiotic. Interestingly, and this is probably my last point on this, is that the prescribing behaviour of local GPs in the area of that clinic can actually affect the client expectations of antibiotics. So that was interesting. I had some people say, well, I know that the local GPs are really careful with their prescribing, and the owners come in with knowledge because of the consultations that they've had with their children or for themselves at the local GP clinic, where they've been told, actually, we need to just hold off. If we don't need to give antibiotics today, let's not. And so that attitude from the local GPs was flowing over into the veterinary consultations. So that was a really interesting one, and it just shows that we are working together, and what we do in each space does matter. Vets had a number of suggestions about how we could help them to prescribe antibiotics more carefully. Continuing veterinary education about antibiotics was suggested, better dissemination of the guidelines, and we've got some really nice traffic light posters to explain the different importance ratings of the drugs that are available. Interestingly, communication skills training. The vets who are really who were having a lot of success at not giving antibiotics when they didn't feel they were needed, had some really good sort of spiels that they just rolled out to say to the client that seemed to really help get the client on board. So I think that the communication skills training has a lot of potential to help vets. Involving reception and nursing staff in an AMS program in a clinic seems to be really important as well, as for those reasons that I said about client expectations. Educating clients about AMR, obviously there's limited time to do that, but there may be, they felt that public education campaigns might help. Shifting the clinic culture to be more egalitarian and more valuing, I guess, the input of all vets so that things can actually change rather than becoming stuck in a particular way of doing things. That's difficult to do, but is something that's worth considering. And also they thought that providing social normative information about how their prescribing behaviour compares with that of other vets might help them. But I guess the question with that is, how do we get that sort of information? I mean, in some clinics we have a relationship and we can get some information about what people are actually prescribing, but most vet clinics don't provide data to any central database, so we don't actually know what most of them are prescribing and whose responsibility might that be. It's a bit less clear than perhaps in the human medical space. Sorry, I've talked a lot. So I just wanted to thank my interview participants, Green Cross Vet Clinics, who have participated with us in a large AMS trial and have allowed us to look at their prescribing data, and my colleagues in the vet school. Are there any questions? I can't actually see the chat where I am. Hang on. Oh, yes, there's something. Well, Anne. Oh, thanks, Anne.
Thanks, Reed. That was fantastic. There are lots of questions.
Yeah.
I'll let you go through them, but I'll also unmute the participants who ask those questions so they can interact if they wish to.
Great. Anne asks, what is the biggest threat to human health? Oh, I'm not going to know the answer to this. Potential AMR arising from the use of convenia in a cat, or an owner going to hospital with cat bite wounds from an attempt to medicate a cat and needing to have IV and oral antibiotics. The genuine cost benefit question, I guess that's a really complicated kind of thing to unravel, because do we know how likely is it that the owner will end up going to hospital with cat bites? It's difficult to know. I guess I would say that we did used to treat cats before convenia existed. And I suppose it is possible to go back to those days when we treated cats without convenia. Yes, there may be some issues with cat bites and wounds. One of the things that might help is one of the vets that I spoke to said, instead of giving an injection, they'd gotten rid of convenia from the clinic altogether because they felt so strongly about it. And where there was a cat that was really impossible to give oral medications, the vet and nurses had decided that they would get the animals to come back in each day for an injection of amoxicillin, or every second day for an injection of amoxicillin until it wasn't required anymore. So people have come up with innovative ways of treating difficult cats, but it definitely is a balance, and it is hard when you're concerned about the welfare of the animal and the welfare of the owner and the compliance. It's not easy. Are there other? Oh, and yeah, Anne says, I've treated a lot of dogs that don't respond with Procoil and with metronidazole. Are there other questions?
Yes, there were a couple of questions in the chat as well from Stephen and from Leslie.
Oh, I'm only looking at the Q&A. Right, okay. Oh gosh. Okay. Yes, fear of client complaints, KPIs at some clinics. Vets are paid on what they invoice, which does create a conflict of interest. So, Stephen, would an inexpensive, sensitive, specific and rapid patient-side diagnostic test solve a lot of the issues of fear, etc.? It would provide objective support. I do think it probably would, but I'm not sure. I'm not sure that we're close to having the sorts of tests that we would need. I mean, arguably, some of the things that we can already do in the clinic, for example, spinning down urine and having a look at the sediment, is not actually done that much, and that would be a helpful step for some urinary tract infection investigations, and we're not doing that. So it's hard to know whether people would uptake the patient-side diagnostic tests. What would be the key characteristics of a novel antimicrobial medicine that would be favoured more than convenia? Route of administration, I assume highly attractive and irresistible dosage form, etc. Yeah, I mean, because convenia is used really for cats, I mean, there's a few small dogs that are really difficult to medicate because they're just vicious, but because it's mainly about getting an antibiotic into a cat, I think it really needs whatever. I would love to see an injectable, long-acting, lower importance antibiotic available for cats. I don't understand drug development or how long-acting preparations are made or anything like that, but that would really be such a great change if we had available to us something that wasn't a third-generation cephalosporin that lasts 14 days. If it was a 5-day amoxicillin injection, that would, I think, be a game changer for vets. Leslie, who works in general practice, antimicrobial stewardship, says day and time of presentation has also been reported in human general practice too. And yes, Leslie's research also suggests a role for receptionists and nurses, but those things I think are under-researched and probably under-recognised, that the role that everyone in the clinic can play in creating that culture, creating the expectations for clients, and also, I guess, maintaining client satisfaction. It's not just the vets, it's everyone in the clinic, and if everyone's on the same page, then it's much easier to encourage things like delayed prescribing, which is a really helpful tactic for many situations where there's uncertainty about the diagnosis and the animal's not deteriorating. Just delaying by a few days to see what happens just makes a huge difference. But yeah, you need everyone to kind of want to do it. And the insights about receptionists, nurses really ring true. Typical conversation is, my cat has X, does it need to come in? And the receptionist might say yes, it might need antibiotics. Clients sometimes say, can you just give me the antibiotics without me coming in? So I think there's a real issue with the way that antibiotics are perceived by the general public, particularly for the animals. I am yet to discover whether they have the same attitude to antibiotics, say, given to their children versus given to their animals. But there does seem to be a bit of a thought that antibiotics are really, really very useful for animals, and that when in doubt, we should give them, which is something we really need to, I think, work on winding back. Steve says the main issue with long-acting injections is the amount of sub-minimal inhibitory concentration time in the treated animal. This applies to all long-acting injections. Yeah. Yeah. So while we are waiting for a better long-acting injectable antibiotic that we can give to difficult animals, it would, doing things like that clinic did with, a series of injections on a daily basis where the client just keeps on coming back in, that prevents injury to the client. It means that we use lower grade antibiotics. It's more work for the clinic, but it's ultimately probably a better result. Getting an angry cat in a carrier is very high risk. That's a good point, Anne. And there's I don't have all the answers to the angry cat issues. Cats should just be better. That would be my biggest wish, is that cats would just be a little bit easier. Can anyone arrange that, please?
Well, on that very happy note, thank you so much, Ree. That was fantastic. And thanks for the fantastic questions as well. And look forward to seeing you at future webinars. All right. Thank you, everyone. Bye.
Thanks, Arjun. Thanks, everyone.